The best magnesium for diabetes is not the most expensive bottle. Magnesium citrate often makes sense when absorption matters, while oxide fits constipation and glycinate may suit a sensitive stomach. None has proven better for lowering A1C, the 3-month blood sugar average. The useful choice starts with why magnesium might be low. High blood sugar can increase urinary losses, creating a cycle that a supplement alone cannot fix. Magnesium helps enzymes move glucose through cells and supports insulin, the hormone that moves glucose from blood into cells. When magnesium is low, that signal may work less efficiently. High blood sugar can spill glucose into urine. That glucose pulls extra water through the kidneys, increasing magnesium loss. Poor control can therefore lower magnesium, while low magnesium may worsen insulin resistance, meaning weaker insulin signaling. Other situations can lower magnesium without involving blood sugar. Chronic diarrhea reduces absorption and removes magnesium through stool. Poor appetite or a diet built around refined foods may provide too little from the beginning. A link between low magnesium and diabetes does not prove that every person with diabetes needs a supplement. People with higher magnesium intake often have lower diabetes risk. However, those diets also contain more beans, greens, nuts, and whole grains. Those foods bring fiber and many other benefits. Association cannot separate the mineral from the entire eating pattern. Blood testing has important limits. Most magnesium stays inside cells and bones, while only a small amount circulates in blood. A normal blood result can therefore miss low body stores. Doctors combine the result with diet, symptoms, medicines, kidney function, and repeated losses. Muscle cramps are often blamed on low magnesium, but many other conditions can cause them. Before comparing forms, read the supplement facts panel. It lists elemental magnesium, meaning the actual magnesium delivered. A bottle may advertise a large compound weight while providing much less elemental magnesium. Compare the elemental amount, serving size, and number of capsules. Some labels list magnesium per capsule, while others list it per full serving. As a result, 2 bottles that look equal may provide very different doses. Magnesium citrate is a practical first option when a supplement is truly needed. It dissolves well and is generally absorbed better than oxide. It can also draw water into the bowel. That helps constipation, but it may cause loose stools or cramping. A smaller divided dose may improve tolerance without changing the form. Magnesium glycinate binds magnesium to glycine, an amino acid used to build proteins. Many people choose it when citrate irritates the bowel. It may feel gentler for some users, although that advantage is not guaranteed. Products often cost more and may require several capsules. Glycine itself does not prove better blood sugar control, and direct evidence favoring glycinate over citrate is missing. Across all forms, clinical trials show mixed blood sugar results, and average changes are usually small. Even then, a supplement cannot cancel excess calories, missed medicine, or persistently high glucose. Benefits appear more plausible when intake is low or deficiency is present. Replacing missing magnesium is different from treating diabetes itself. That evidence gap shifts the comparison back to absorption, tolerance, cost, and purpose. Magnesium oxide is inexpensive and packs more elemental magnesium into a small pill. However, it dissolves poorly and is absorbed less completely. More unabsorbed magnesium stays in the bowel and pulls in water. That makes oxide useful when constipation is also present. It is less attractive when the only goal is restoring magnesium efficiently. Magnesium chloride, lactate, and aspartate dissolve well and tend to absorb better than oxide. They are reasonable alternatives when citrate is unavailable or poorly tolerated. Chloride may still loosen stool in some people. The form matters less than reaching a usable elemental dose without ongoing diarrhea. Diarrhea defeats the purpose by creating another route of loss. Magnesium threonate is promoted for brain penetration, while malata is promoted for energy. Those claims do not establish better blood sugar control. Premium pricing can hide a low elemental dose. Added vitamin blends may also raise cost without solving magnesium deficiency. Diabetes should not turn a marketing story into a medical advantage. Product quality matters because supplements are not approved like prescription drugs before sale. Look for clear elemental dosing and independent quality testing. Avoid blends that hide individual amounts behind one total. Certification does not prove better blood sugar control. It only improves confidence that the bottle actually matches its stated label. The decision begins with 4 checks: deficiency likelihood, kidney function, constipation, and tolerance. The reason for supplementation should decide the form before price or marketing does. For normal kidneys and no bowel problem, citrate is often a sensible starting point. Glycinate is reasonable when bowel tolerance drives the choice. Oxide makes more sense when a laxative effect is also useful. Once a form is chosen, timing is mostly about tolerance and interactions. Taking it with food may reduce nausea. Splitting the dose can reduce bowel effects. Some labels or online advice favor bedtime, but diabetes does not require that schedule. A schedule that can be followed consistently is more useful than a supposedly perfect hour. Food remains the safest foundation because it brings magnesium without a concentrated dose. Useful sources include pumpkin seeds, almonds, beans, spinach, and whole grains. Replacing refined snacks with these foods adds fiber and may improve meal quality. The benefit does not come from magnesium alone. Portions still matter because nuts and seeds are energy dense. After starting a supplement, judge the trial against the original reason for taking it. If the goal was constipation, stool response matters. If a low level was documented, repeat testing after several weeks may be appropriate. Daily glucose can move for many reasons. Do not credit every better reading to magnesium. For adults, the upper limit from supplements and magnesium medicines is 350 milligrams daily without medical supervision. That limit does not include magnesium naturally present in food. Higher supplemental amounts commonly cause diarrhea, nausea, and cramping. The label's elemental amount is the number to count. More is not better when absorption falls and side effects rise. Magnesium can block the absorption of some antibiotics and bone medicines when taken together. Separating doses may prevent that problem, but timing depends on the medicine. A pharmacist can check the exact spacing because different products require different intervals. Kidney function changes the safety calculation. Healthy kidneys remove extra magnesium, but impaired kidneys may allow it to accumulate. Severe excess can cause weakness, low blood pressure, slowed breathing, or an abnormal heartbeat. People with kidney disease should not self-treat with concentrated magnesium. New severe weakness or breathing trouble needs urgent assessment. If food intake is adequate and ongoing losses are absent, a supplement may have little to correct. Money and pill burden then rise without a clear target. Record the reason, product, elemental dose, bowel response, and any medicine spacing. Review that record after several weeks. It can separate poor tolerance from an ineffective plan and prevent unnecessary switching between expensive forms. The best magnesium for diabetes is the one matched to a real need, safe kidneys, and a tolerable bowel response. Citrate often makes the most balanced choice. Glycinate can be useful when tolerance matters. Oxide mainly earns its place when constipation is part of the goal. None replaces proven diabetes treatment. Medicine simplified. That's what this channel does. If you want more, hit subscribe. This is not medical advice. Consult your doctor.